Okay. Thank you very much for being here with us today on this at this debate on video laryngoscopy, on what device you may want to use best. So my name is Andrea Vannucci. I'm a Vice Chair for Quality and Safety at the University of Iowa, a liver transplant anesthesiologist. And let's say that my interest for airway management is the one of an occasional airway anesthesiologist. It's mainly a patient safety. But the other two speakers are very well known in their field. They have published, they are familiar with the literature, and importantly, they work almost every day with difficult airway. And so the idea is that they can provide an informed perspective and some provocative idea. I don't know if we always have certainties about how we should handle certain airways, but listening to articulated speakers that know their way around, that's certainly going to be informative. So basically, this is a kind of an outline of the session. We want to review a little bit types and features of video laryngoscope, review briefly the current evidence. But what is really relevant to us would be to try to provide information that can help clinicians. We're thinking we were going to have trainees. It seems to me that there is probably more an audience of expert clinicians. But anyway, how to choose the right tool for the right patient. And then information that may help individuals or department to choose what devices to use on their practice. And we have a few rules. So Dr. Cavallone is going to speak in favor of channel device. Dr. Negenzikla kindly accepted to speak in favor of the Stylet devices. I don't know if he really feels so, but he's going to let us know. And to try to keep the debate on topic, so the idea is that everybody's going to speak one at a time. We're going to make sure to address any counter argument. We will try to stay on topic, to use evidence. Importantly, this is going to focus only on adult patients. We are not addressing pediatric airway. And we were thinking of keeping the questions that with the audience for the end. But if you have any burning questions, let us know. Let the speakers know. So I'll try to review briefly a little bit the history of video laryngoscopy. And so this was the cover of ANA in April 2010. The issue of the journal included several articles on airway management and had this nice cover trying to reconstruct the timeline of laryngoscopy, video laryngoscopy, starting from the 40s, the Miller and the Macintosh plate, going to the fiber scope and to the video laryngoscope. And you can see that in 2010, all the instruments, or most of the instruments that we currently use were already around. We have the glide scope, the CMEC, the Pentax. And that was an interesting period also because in trying to learn how to use these instruments, there was some reflection on the approach to the airway. In the late 90s, early 2000, the French group by Adnet started doing an MRI study to look at the airway, and one of their first goals was to show that the theories of the alignment of the axis that I was taught as a resident did not really respond to reality. You can see in these three images a patient in neutral position with the extended neck, sniffing position with a pad under the head, and he was showing that the axis of the mouth, the pharynx, and the larynx never aligned. And so a few years later, again with an MRI study, Greenland from New Zealand came up with this theory of the two curves that separated the, let's say, the entrance of the tube from the mouth to the larynx, to the arytus. And he made some interesting reflections that I thought were helpful for clinicians, because he started distinguishing video laryngoscopes in those that require a midline approach over the tongue and those that are inserted laterally along the floor of the mouth. This second category is the traditional, the same mechanism used for direct laryngoscopy, in which we insert the blade in the mouth of the patient, we sweep tongue away. And the point that that made quite clearly is that the devices that need a midline approach require a system to ensure that the tip of the tube will be in front of the vocal cords. And this could be either a stylet or a conduit. And other people try to look at this same problem. This is a study by Levitan, in which again it shows that if you're using a Macintosh type of blade, like for direct laryngoscopy, you don't need a lot of curve at the tip of the tube. While if you use a hyperangulated blade, then you need to make sure that the stylet helps the tube to follow the profile of the blade and of the oral cavity. And in those years, also the first studies came out about predictors of failure of laryngoscopy. This is the study by Aziz of 2011. He identified the previous radiation treatment of the head and neck, a thick neck, a thyromental distance less than 6 centimeters, limited cervical motion, and as predictor of failure. And this was a study done in 2 different institutions. It was done, I think, in Oregon and Michigan. One of the 2 institutions had a higher failure rate. And the higher failure rate was probably related to less experience of the clinicians of one institution with the devices. In 2015, 2016, there was the first Cochrane meta-analysis comparing video laryngoscopes to traditional direct laryngoscopy. And at the time, they had a limited number of studies, about 60 studies, about 7,000 patients, and they concluded that video laryngoscopy may reduce the number of less failed intubation, especially if patients are at risk of a difficult airway, and may improve the glottic view and reduce the laryngeal airway trauma. But there were no evidences that they could help decrease in the number of intubation attempts, the incidence of hypoxia, respiratory complications, and so on. So clinicians and researchers keep working on them, and in 2022, based on data up to 2021, a second Cochrane review came up with some more detailed granular information. So they divided the video laryngoscopes with the same criteria used by Greenland in his 2009 paper. So we have the Macintosh video laryngoscope, like the original CMEC, the hyperangulated, like the glide scope, and the channeled video laryngoscope, like the AirTrack, the Pentax. And they saw that all would help with reducing failed intubation. That Macintosh and channel devices would help preventing hypoxemia during the intubation, but not the hyperangulated blade. All these devices, all these classes of devices would help first airway attempt success, and interestingly that the hyperangulated blade were associated with a reduced number of esophageal intubation, probably because that device would offer a better view of the esophagus. And again, Dr. Aziz and collaborators identified a new series of predictors of failure, this time not only for a glide scope, but also for the CMEC D blade, the hyperangulated blade of CMEC. And interestingly, they found that sniffing position would increase the chances of failure, then otolaryngology and cardiac surgery, and then small mouth opening. And more recently, there was this study by a French group that identified some predictors of failure for the channel device, for the AirTrack in this case. They had quite a sophisticated approach. They would try to identify patients that they would need to start with an enhanced approach to airway management, And that meant that they would either load the tube on a fiber optic, or they would be ready with a stylet to do intubation. And reduced mouth opening, increased BMI, Malampati 4, previous difficulty intubation, and retrognathia was all associated with an increased chance of failure of channel devices. Anyway, what we have been seeing, and this is from a study from the Danish National Register that was tracking data in 2016 up to 2016. Basically, what they were able to show is that video laryngoscope, this is the straight line, were increasingly used to deal with anticipated difficult airways. That this was associated with the increasing use of video laryngoscope was associated with a decreased number of attempts at intubating the airway, so more success, more safety, and a decreased number of intubation failure. So video laryngoscope use is expanding, and I try to look at some market analysis, and the idea, so we have some information. 40% of the video laryngoscope market is in the US, and it's growing at a rate that probably by 2031, 2032, it's going to double. And basically, the increased use of video laryngoscopes involve all end users, operating rooms, intensive care unit, ED, and also pre-hospital care. So they are expanding. And now we are coming closer to the real topic of our conversation today, which is the comparison between channeled and stylet-based video laryngoscope. We have a couple of studies that started to look at this in a different way. There is one that Laura and I completed, trying to look at studies in which the authors try to do a direct comparison between different types of video laryngoscope. And there is this other more recently published review by De Carvalho et al. In anesthesia, which is a very large meta-analysis of including more than 4,000 patients, 300 studies, in which they still compared the video laryngoscopes against direct laryngoscopy, and they started finding some introduction. Now, we wanted to keep this spontaneous, and so there is only one presentation, but I would like to invite now Dr. Cavallone to come up and move forward.
And start explaining why channel laryngoscope are so much better than stylet laryngoscopes. And well, before I move forward, I just wanted to go back to this slide that shows the predictors of channel video laryngoscope failure. I just wanted to stress that this paper that highlighted these predictors of failure for channel laryngoscope was a paper exploring the use of a specific algorithm where air track was used in patients that had very significant predictors of difficult airway, like a short thyromental distance, neck immobility, BMI, and high Malampati score, so all the classical bedside predictors. Those patients that had 2 or more of these characteristics to an elevated grade were differentiated to be treated in a specific fashion, where their first attempt would be air track, and then instead of DL, which was considered the routine treatment, the routine technique used for intubation. And even in these patients that had several predictors of difficult airway, air track was successful the vast majority of the time, even with spinal cord immobilization associated with other difficult airway factors, for example. And so a very small percentage of this population needed enhancement of the air track, but with the enhancement of air track plus use of a stylet, air track in the sense of an example of channel laryngoscope, with the use of a stylet or with the use of fiber optic scope associated with this technique, they could intubate 100%. So they had 0 failure in their population of high-risk patient for very severe predictor of difficult airway. Just wanted to clarify that. So they are not really predictors of failure for channel laryngoscope in any situation, but they are predictors of failure in this very high-risk population. So that said, We have been trying with this review to find the direct comparison of the performance of channel versus non-channel video laryngoscopes to find specific clinical situations in which channel versus non-channel laryngoscope would be compared directly in the same trial, and we tried to see if it was possible to identify the one type of device was going to perform better than the other according to certain commonly utilized outcomes. So because unfortunately direct comparison, I'm not talking about comparison of one type of video laryngoscope with DL, which is the most widespread type of comparison, but just one type of video laryngoscope of the channel kind directly compared with the one type of video laryngoscope of the unchanneled kind. The papers eventually that we could find were not very many. There wasn't a lot of evidence out there of these direct comparisons. What we decided to use is this heat map where the favorable outcomes that we were looking for, like for example 0% intubation failure, 0% esophageal intubation, highest success rate at first attempt, were highlighted in green, while the worst outcomes were highlighted in red, and the number of papers to the opposite. When we would find a higher number of paper illustrating this direct comparison, reporting on this direct comparison, the numbers would be in green, while the lower number of papers would be in red. So by doing so, we created these maps where green areas are areas of favorable outcomes and more papers supporting those favorable outcomes in that direction, either the channel laryngoscope being better or the unchanneled laryngoscope being better, and of course a red area would indicate the opposite. So more of a visual hint of where the evidence is trending, where the evidence itself is not very strong yet. So, and these were our results for the general population, not really telling there a little bit more of information on performance of the channel laryngoscopes. Our numbers are still very low. We're talking hundreds of patients, not thousands of patients. But the level of performance between channel and unchanneled laryngoscope is not very different. The same type of consideration in use of heat maps by Carvalho, even more recently. Both studies are from 2025. This came out just a few months later. This is a study, though, that includes hundreds of thousands of patients. And however, it includes papers where video laryngoscopes are compared with direct laryngoscopy. So both channel laryngoscope and stylet-based laryngoscope, video laryngoscopes, as they perform compared to DL. And there we see that they seem to find that channel video laryngoscope tend to perform better than unchanneled video laryngoscope when compared directly with DL in very many categories. The failed first attempt intubation, much better. So the comparison always favor specifically channel video laryngoscope, and in general favor video laryngoscope. Difficult intubation, difficult laryngoscopy, rate of esophageal intubation. Again, video laryngoscopes are favored compared to DL, but in particular, channel laryngoscopes seem to perform better. And again, here, preference by anesthetist, performance in specific clinical scenarios such as cervical immobilization, obese patients, intensive care units, emergency department. You can see the first line, channel video laryngoscope seem to have the always favored outcomes compared to DL, more favorable outcomes than the comparison between unchanneled video laryngoscopes and direct laryngoscopy. So now, this is what we know so far, and what should guide our choice of devices, we think, when we work clinically every day. The evidence is not there yet, but we start gathering some important information. And definitely, you know, the most recent guidelines of the European Society of Anesthesiology indicate that there is a trend toward replacing use of video laryngoscopy as a first choice compared to use of direct laryngoscopy, that they are encouraging and recommending to adopt as widely as possible, that independently of the fact that they are channel or unchanneled video laryngoscope. Now, without further ado,
Sorry to interrupt you, just as a moderator. No, 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 no. Stay there where you are. From now on, Dr. McKenzie can interrupt you.
yeah, of course.
Suggest a different
Never.
perspective.
No, it will not interrupt me because I will stop very frequently.
And other suggestions or considerations.
Now we have our first clinical case to propose, which is a case of limited mouth opening of a patient status post radiotherapy. This patient had a facial reconstruction and with free flap, and then had radiation. And as a result of his multiple surgeries and radiation therapy, he had a very limited mouth opening and a trismus. Very limited, not limited to the most extreme level that we sometimes see. His interincisor gap was around 2 centimeters. So definitely less than 3 finger breadths, but still 2 centimeters. And now the question is, what would you choose to intubate this patient and why? And I don't know if you, from the audience, want to, yeah.
I will go by awake fiber optic.
Awake fiber optic.
Good choice. Good choice.
Okay, sure. And with everything being equal, would you want a nasal fiber optic or try to perform an oral fiber optic?
I think nasal.
Nasal, okay. Okay, and Dr. McKenzie, do you have any comment regarding that?
Yeah, I think it's a very prudent choice. We just had a small discussion with, by the way, there are very bright minds in this audience, including people from Society for Airway Management, Dr. Jim Ducanto, Brazilian team, including Dr. Perrin, and I would love to hear their opinion as well. But we were just discussing that the characteristics of the blades that the manufacturers of the video laryngoscopes put out could be misleading. You can read, for example, for the McGrath video laryngoscope blade that it can negotiate the mouth opening, although they do not specifically say that, but they say the blade is 14 millimeters only, so you conceivably can insert it in this patient. What they don't mention is that the blade, that blade and all other blades, they fan out. So you actually can probably insert part of the blade into the patient's mouth, but it doesn't guarantee that you're going to reach deep inside the airway and actually visualize the structures. So I think you have to be very careful. And as Dr. Van Nucce showed that slide, and it for the predictors of the failure for channel devices, and that goes along with Mike Aziz's study for all video laryngoscopes. The limited mouth opening is going to be a predictor of failure. Okay, and so the prudent approach when you clearly anticipate difficulty is to do something different, maybe to do an awake intubation. And I agree with you. In my opinion, the nasal flexible scope intubation is always easier to do as compared to an oral approach where you need to go around the curve, while the nasal intubation most of the time gives you a straight shot to the larynx.
And Laura,
However,
what did you do in this case and why?
well, I will tell you that this patient, unfortunately, had to had surgery many, many times, and he had prior experiences with awake fiber optic intubations, and definitely prefer not to have one. He asked me if there was anything I could do to avoid having to have another experience that he found pretty traumatizing. I tried to tell him that I could try to make it less traumatizing, that I completely understood his concerns and talked to him into a awake technique. However, he couldn't be convinced easily. What I convinced him to do was to let me take an awake look at his airway with the air track. So with this channel device, while he was still awake, I topicalized his airway, and I inserted the air track, and I visualized his vocal cords, and I had a clear view of his vocal cords. The air track, the blue model, the regular adult size, only requires 1.8 centimeters for insertion in the mouth, which I would never take for granted. So I confirmed that while the patient was still spontaneously breathing, he tolerated the insertion of the tip of the air track as much as he would have tolerated the insertion of a plastic oral airway. And then once I had that reassurance, I put the patient to sleep, and as you can see, I inserted the device in his mouth, and in less than 5 seconds, I obtained a perfect view of the vocal cords, and I inserted the breathing tube, and I intubated without any difficulty. And again, I did that after an awake look, which was absolutely perfectly tolerated by the patient after proper topicalization of the airway. And then I put the patient to sleep confidently, and everything went as expected. Now, so I wouldn't say that I would necessarily recommend the use of the air track in any patient with trismus. I would just say that if the trismus is not below 2 centimeters, and there are other reasons that would indicate a preference of the patient, either to avoid a completely awake technique, or anyway, if there are also factors like the availability, for example, of flexible scopes, another option would be to try to utilize this instrument with the patient awake. That is normally better tolerated than nasal flex endoscopies by most patients. One caveat, narrow mouth opening in the horizontal direction, yes, if the interincisor gap is at least 2 centimeters, but I had some difficulty in other occasions. This is another picture of one of my patients, when the narrow mouth opening is narrow in the sense, in the more of a vertical sense, is when you have this arch palate with the crowded mouth of teeth, sliding the air track in a small mouth in that direction could be problematic. So this is something to keep in mind.
And if I may step back just a moment, did you paralyze that patient after putting him to sleep or not?
Yes, I did paralyze the patient.
I have a question. So when you put this patient to sleep, did you take the air track out, or you kept it in and put the patient to sleep and then continued with the intubation?
I took it out after the look.
Took it out. Yeah, just my personal opinion. I mean, I personally is not a big fan of the awake look. In this particular patient, the patient refused an awake intubation. So, but in general, I feel that if the patient does not refuse an awake approach, I feel that the awake look could be misleading in many patients, and it also could give you false positives and false negatives. If your topicalization is inadequate, you may get a bad view. If the patient is struggling and doesn't give you a good effort with mouth opening, for example, again, outside of this particular case, you can get a false negative. You also can get a false positive. You get a good view, and then you take the device out, and then you put the patient to sleep, and then everything collapses. And then you go back in, and then you have trouble actually visualizing the anatomy again. That's why I was asking, I mean, do you think it would have been better to keep the device in, maintaining the view of the glottis, and then put the patient to sleep, and either with high-dose remifentanil propofol or small-dose succinylcholine, for example, and intubate the patient while maintaining the visualization?
Sure, it could have been a perfectly good choice. The reason why I did that is that behind the opening of 2 centimeters of distance between the teeth, I could see a Malampari 1. The patient was very lean, And I felt in this particular case the size of his tongue was not a large tongue. There are a lot of situations in which I would definitely be concerned about collapse of the soft tissues. Obese patients, for example, I would never do that in an obese patient. I would say that aside from the radiation, this patient had all the other predictors of difficult intubation and landmarks that were extremely favorable. So I would say that this case for me was more like a little provocation for you, rather than thinking that it can be a very a perfect choice in any circumstance. It has to be adopted in very selected patients. But the point that I wanted to make is that the insertion of the blade was easy and uneventful, and it could be carried out with the patient spontaneously breathing. I am absolutely confident that it could be. This patient refused it and was the right patient to me that could be put to sleep. But in other situation, I performed the same type of intubation with the patient awake or spontaneously breathing, depending on the situation.
No doubt. Because I'm pushing the non-channel technique here, so let me give you my view of the advantages of the non-channel technique, or what I call the so-called steering technique that we use with the glide scope or the CMAC system, for example, among others. I think there are maybe three biggest advantages to the channel devices. One is that we can use the normal geometry blades, to which many of us are accustomed to, right? So the current video laryngoscopy systems, both glide scope and CMAC, allow you to attach the video mag blade, Miller blade, okay? And you can use your motor memory and do kind of regular intubation, but assisted with the video guidance with a normal blade. So this is one. Number two, and in addition, you have the flexibility to use the hyperangulated blades with those systems. So you have the choice. With the channel device, you don't really have a choice. I mean, you just have one blade that's supposed to fit all the anatomy. So this is number one. Number two, the air track is not really a true video laryngoscope. It's an optical laryngoscope. It has a collection of optical lenses that do the same thing as the hyperangulated blades. It provides the view around the corner, but it does not have a video camera. So as a result, the resolution is really inferior.
It does. It does have. Oh yeah, oh yeah. For several years it had. This patient, you can see the camera in this patient. You see the camera there?
No, this is the camera attachment.
Yeah.
Yeah, no, I'm talking about the video chip.
Oh.
There's no chip camera. There's no high definition resolution. Okay, so as a result, if you compare the quality of the image, it's always going to be inferior in the air track. Okay, and even on the Pentax airway scope that I believe now actually maybe has been discontinued for distribution, unfortunately, in the United States, that was a true video laryngoscope. That had a much better image, but the screen was very small. So the image quality is the second. Third, the size of the screen of the video monitor. So with the air track is just that what you get, just very little. For many difficult airway cases, for challenging cases, it's highly beneficial to have multiple people helping you to look at the same time at the anatomy and help you identify the anatomy, provide intelligent assistance, not only verbally, but also actually manually, you know, if you need any, you know, laryngeal manipulation or something like that. So I think these are the three big advantages as compared to the channel devices.
The newest, the new advanced model of the AirTrack does have a camera though. That was just out.
Okay, very good.
It's just a camera attachment, yeah.
Right. But all this kind of cumbersome, right? I mean, you have to, you know, make sure the monitor is configured, make sure, you know, I mean, it works, and then it works, and then it doesn't work, and all these things. I would say there's one exception. So now Ambu actually redesigned the system completely. It's called, have you guys seen it? Exactly. Right, exactly. Exactly. So you can easily swap. So now they have a channeled blade. So now you can use the Ambu system for the channel blade and all the others, right? So, so that could be, you know, an advantage to using the AirTrack. I also want to say a couple of more things. So,
but we have to go to more cases.
More cases, okay.
Sorry.
All right.
Dr. Mackenzie, we are looking forward to hearing your opinion.
Yes.
Staggering them a little bit.
On this large goiter case, anyone that would choose either a channel or unchanneled video laryngoscope for this case?
You have to show the picture.
I just did.
Ah, okay.
Would anyone put this patient to sleep? Okay, no.
I would.
I would not.
You would not?
I would not.
So the, if you look at the literature, the benign disease almost, yeah, it does provide the displacement of the trachea, okay? But it does not compress to the trachea to the degree, I mean, obviously there's going to be some exceptions, yeah, right? But as a rule of thumb, it does not provide a compression of the trachea to the degree that you won't be able to pass a small endotracheal tube in, okay?
Yeah.
So
still, I wouldn't put the patient to sleep. I would not be confident that I would be able to mass ventilate the patient and intubate the patient rapidly enough with potential deviation and even what you consider a minor degree of compression for me would still be concerning enough, especially if the patient is symptomatic. And this patient was symptomatic. So what I did, once again, I kept the patient spontaneously breathing for the insertion of the AirTrack. This time I didn't induce the patient. The patient was kept spontaneously breathing, well topicalized, and I had high flow nasal oxygen throughout the procedure, and I loaded in the channel video laryngoscope, I loaded a recurrent laryngeal nerve monitoring tube. You can see the wires there in the corner. And at the same time, the ECMO team had just finished cannulation for ECMO. So the patient was connected to the ECMO machine, and ECMO was started as I was starting to maneuver the airway, and I didn't start until they gave me the okay. This is how severe the compression was, and the concern for complete airway collapse, loss of the airway, and potential hemodynamic instability also for this patient. And so the patient here is not really easy to see. She was head up, in the head up position as I was accessing the airway, as I said, spontaneously breathing awake, just minimal sedation, and I intubated with the aid of the AirTrack for passing the tube through the vocal cords. But then I also had an assistant inserting a fiber optic scope, a flexible scope through the tube, so that we could also explore the passage through the trachea and have a clear view of the trachea and the points of narrowing and potential damage in the tracheal wall.
Yeah, but this could have been managed also with a non-channel device the same way, correct? Right, exactly. So, yeah, exactly. So, dual video is an essential technique if you think about the tracheal compression, so you can navigate through it.
Yeah, I would argue that the AirTrack requires less force to be exerted on the floor of the mouth, and in my experience, patients tolerate it better.
Not compared to the, I don't think there were any studies directly comparing compression of the floor of the mouth between the channeled and non-channeled devices.
Yes, actually there are.
With the direct laryngoscopy.
Okay, well,
By
sorry.
the way, you're familiar with the, okay, well, here we go. You're familiar with the study by Taboada, who, from Spain, 2024, who looked at the awake intubation using air track and the D-blade?
Air track and the D-blade 2024?
Yeah.
No.
Yeah, so awake intubation, that's something we're talking about. The success rate for air track was around, by memory, citing by memory, way lower, way low. It was, I believe, 90 patients, 45 in each group. Air track success rate around 80%, I believe, and D-blade more than 90%. 76, I believe, was for air track, actually, to be exact.
And do you remember what kind of users? So what was the experience of the users?
I
with
don't
the
remember.
devices?
Well, I would presume that if it were an awake intubation, that would have been the experienced users. I would presume.
Yeah.
But that's, you know, that's the other area, right? I mean, heterogeneity of the studies
Exactly.
and this
Different
and
type of
that,
providers, experience
comparing
versus.
the devices.
How difficult was to pass the tube? Not difficult at all.
That's exactly my point.
I have personally not had problems passing the tube. I have though seen tracheal walls that were compromised while passing with the breathing tube, and I provided I think helpful information to the surgeon, and also as far as how the patient should be managed postoperatively after the resection by observation made together with the surgeon while we were passing the scope. So we could still have interesting information.
Well, that's exactly to my point. I'm not aware of the studies that would have shown compression of the trachea to such a degree with a benign disease. Using the flexible scope it was a great choice because of the tortuous pathway, because of the displacement of the larynx, so dual video intubation. But I think any device in combination with a flexible scope would have been effective here.
The study from Taboada was 84% cases favored to CMAC D-blade compared with 62% of.
All right, here we go.
Yeah, and this is mini first attempt success.
Right, the first attempt was the primary outcome. Yeah. Thank you for that.
Well, there is the study from Fabrice Cook, and that demonstrated 100% of success rate with the air track as the primary device that we used for intubation in patients that were known to be, expected to be very difficult airway by many parameters.
May I point out a moment to another interesting aspect of the technique, of the combined technique, the dual technique, is that in this case you were placing a nymph tube to monitor the laryngeal nerve function, and so you could have also make sure that the position of the nymph tube was correct.
I also showed the wire.
Sorry, I did miss that.
Now, another different case, a morbidly obese patient. For uvulopalataloplasty and terminate reduction for severe obstructive sleep apnea, history of hypertension and controlled GERD, and for obesity we have mixed data. Our smaller review of direct comparison didn't find any particular answer as far as would channel laryngoscope be better or unchannel video laryngoscope would be better to manage these patients. So unclear response. If anything, the little evidence we found pointed in the direction of unchanneled video laryngoscope. However, from this breakdown of the Carvalho's results, the other study, much bigger study comparing different type of video laryngoscopes with DL, the evidence seemed to be in favor of channel video laryngoscope for use in obese patients.
May I just make a comment?
Please.
So when you read the studies, I think it's important to understand what we're looking at. So when you read the studies and you look at the Sucra heat maps, I think it's important to understand that this is not the statistical comparison, okay? So the odds ratio, so it's important to read the results very, very clearly and attentively. So if you look at the odds ratio, the odds ratios are pretty much the same. Okay, odds ratios for the channel devices, non-channel devices, or normal geometry blades like the CMAC blade, okay? So the odds ratio tells you how one device is going to perform compared to other device, one-on-one, okay? So the heat map tells you what's the probability of the performance of a certain device among other devices. And what it basically tells you that it is likely, this heat map, it is likely that the channel blades may be the best, although we cannot exclude that the hyperangulated blades will perform the same. That's all.
In that particular study, the odds ratio, the only significant one is for the channel devices. All the other odds ratio cross the
Touch the
unit.
mid-
No, if you look
Yes.
at confidence intervals, they all...
No, they touch, it's here, it's in the forest plot at the bottom. You see, it's not only the heat map, there's a
see from
forest
here.
plot at the bottom. That's what, so they touch the line of no difference, so for the other video laryngoscope.
What was, you were talking about the obese patients?
Yeah, yeah.
What was the odds ratio? I don't see from here.
I don't have the numbers here, but you can see visually that.
Something like 0.7 to 0.95.
The confidence intervals overlap.
But no, but there's no overlap with the midline, the reference line of no difference. So it's the only one that doesn't touch the reference line of no difference.
Okay.
And that's why it's interesting, because they could do the forest plot, not just the heat map. You can visually see also that aspect, which is in fact very important.
Yeah, we've known for a while, even before this meta-analysis, that for the C-spine compromised patients and for the obese patients, the channel devices may be performing better. We've known that. And for the C-spine, I mean, we're going to have a case with the C-spine, in particular because the movement of the C-spine is significantly less compared to the glide scope, for example. That's been known. That's been known. I just want to make one comment regarding the Carvalho study, by the way. So I believe it was like 290 cases that were selected as a result of something like that. And 90% of those cases were the mixed general surgical population. Okay? So there was a small section of the, I believe like 20 cases, something like this, obese patients, and also a very small section of the C-spine patients. There were no other difficult airway patients, okay, like the head and neck cancer, the severe OSA, for example.
The literature just not there yet. So.
Right. Now, my point is that the majority of patients is the mixed general surgical population. So you basically, take the patients and you look at the unanticipated difficult airway, okay, that you may be encountering. Or you're just basically doing the population study, okay, as opposed to just studying and comparing the devices in certain high-risk surgical patient populations. And this is the big limitations of all these comparisons, because the number of patients is very small, there's huge heterogeneity. I mean, it's really very difficult to make definitive conclusions. The skill of the operator, the use of the adjuncts, ICU versus the operating room, all this pulled together, including the Carvalho study, by the way.
Well, the Carvalho study, though, had 244,000 patients, so
No, I'm saying the number of studies in the ICU and emergency department was included in this analysis. Okay, in addition to the operator, the majority were operating room, but not only. So everything is pulled together, and until we do
Sure.
a nicely done randomized study, and I think it needs to be the crossover study. So if you fail, you go to another device. That will increase the power. That will allow to do probably not thousands of patients, but maybe 1,000 patients. I don't
See,
know.
the lucky thing, in a sense, is that patients that have truly difficult airways, as you well know, are a minority. So 0.1 to 1%, depending on the populations, right? So this study is going to be very, very difficult to set up on the patients that are most of interest to us.
Yes, but you wouldn't study the general population. You would study the subsections of the surgical patients where you know that the incidence of difficult airway is much higher.
Yeah, I'm just saying it's going to be difficult to have very high numbers of these
But
patients.
you do the multi-center trial.
Sure, absolutely. But it's taking time to collect this
Of
data.
course, yeah. No, my point is only that when we look at this data, we have to just approach the data with a grain of salt and understand the limitations of all these studies, of all this meta-analysis, and read the results very, very attentively.
Mm-hmm. Yeah. So, do we want to wait and talk about the obese patient with
Maybe
another case?
someone
or
from the audience
someone
would
from
want
our-
to pitch in. And Jim, what would you do?
One of the things I'd like to make a comment about is when we're placing these devices, we're just doing the scissor maneuver, and if you just use a simple tongue depressor, all of these devices become a lot easier to use. I use a metal one in simulation because the wooden ones break, but clinically, why are we relying upon the first medical device known to the human race was the finger, and the second one was the stick? Why are we not using the stick to help us place these laryngoscopes? That's the first thing. So with a patient like this, you could place just about anything you wanted. If you place the tongue depressor, push the tongue into the floor of the mouth to lift a little bit. And I think that a hyperangulated channel device would be perfect for a patient like this. By definition, those channel devices are hyperangulated, but if you go to the slide with the colored things from your study, go forward, I think. Forward.
No, it's
forward.
before.
Keep going. Not that one. It was the really simple diagram, the really simple one.
Our study, this one?
It was your study. Was it your study? Had the really simple thing that showed the percentages from the channeled going down to channeled, hyperangulated optical stylets or something like that. It just looks to me that what you're showing here is that you're failing in tube delivery. You're not telling me that you're not visualizing. I think one of the major issues here is that we're failing with tube delivery, that we're visualizing what we want to see, but we can't get the tube in. So what that data was showing was that you had a higher success rate with tube delivery with the channel device. That's what I'm seeing from that graphical display. It was a very simple slide that we had up there a moment ago before we switched back. It wasn't
Sorry,
that one.
I'm not sure.
Anyway,
Andrea, do
I
you-
mean, that's kind of my...
So these are the images with the odds ratio and the different devices listed on the left. And you are referring to the general population?
I think so, yeah.
So,
This one?
this one, maybe?
It was a really simple, I thought it was, there was just one column with
Oh, that's probably when we enlarged.
Was it?
No,
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 I just
we'll
sorry.
find it. We'll find it.
This
This one.
one. Okay. Yeah.
It's tube delivery. This is I just look at this, I say the issue is the tube delivery, not the visualization.
Which is a well-known issue with
But
the...
how could you say, I'm interested in your reading of the, how would you say that is the tube delivery? It's possible, but how could you say it from this data?
Well, I can tell you, with regard,
no, but that's like-
with regard to the obese patients in particular,
This is
right?
yes.
Look at the study of the obese patients,
Yes.
and the
Success.
laryngeal visualization, grade 1 or 2, There's virtually no grade 3 or 4 with video laryngoscopy. Yet the success rate differs dramatically. You look at Rutzler's study with the McGrath, for example, 95% success rate, first attempt. You look at other studies, below 80%. Absolutely, I agree with you. It's not the visualization.
I just wanted to point out that while the Cochrane review had the McCormack degree, so the view that was seen by the clinicians was reported, we don't have this data in this study, so it's difficult to jump to that conclusion. Your reasoning is plausible, but you don't have the data, while in the Cochrane review you could find that data.
Yeah, difficulty is not specified, and I think we don't have much.
No, let's try to do at least one more. Let's go to Dr. McKenzie case.
Yes.
So that he can.
Yes, the tumor at the base of the tongue and disability.
Ah, okay. Well, this is a great case. So it needs the audience participation, okay? So my case, in the beginning of the era of video, no, not in the beginning, in the middle of the era of video laryngoscopy. So you have the patient who presents for lingual tonsillectomy and comes to Stanford from outside institution where they couldn't intubate her. Multiple attempts, awakened the patient, tried to do an awake intubation, failed. She was miserable. She now needs an operation, and she refuses an awake intubation. It was such a bad experience. She just do whatever you want, but just no awake intubation. Okay, and for lingual tonsillectomy, the nasal intubation is preferred by the surgeon, right? So they have unrestricted access, and it's requested by the surgeon. And you want to switch?
Yes.
You want to switch?
You want to? Sure, please. Go ahead.
Right. So this is the patient's exam. She has a decreased mandibular protrusion, as you can see on the right. Normal thyromental distance. She's obese. Cannot identify the cricothyroid membrane. Large neck circumference, but very good mouth opening. Okay. How would you devise the strategy? I mean, how would you? So nasal intubation is requested. Multiple predictors of. She's a known difficult airway, right? And as we know from the literature and probably from your experience, the history of difficult intubation is probably the strongest predictor of the future difficulty, okay? So we know known difficult airway, refuse an awake intubation, multiple predictors of difficulty, nasal intubation. How do we do it? How do we devise a strategy? And when I talk to my residents, I always tell them, you know, what's your plan or strategy? And I said, the glide scope. So the glide scope is not the strategy. I mean, can you ventilate and oxygenate with a glide scope? And you cannot. So you need to devise the strategy along the oxygenation pathway and along the intubation pathway. How would you devise your primary and secondary oxygenation pathway for this patient? And then the intubation pathway. Any thoughts? Yeah. High flow, perfect. But you're basically going to be doing an asleep approach. Right, but there's going to be propensity towards tissue collapse, no matter what. I mean, in this morbidly obese patient, that's probably going to be, you can try it. I mean, we can try it. Let's try to select the best of it. That was before high flow nasal oxygen, by the way, before that era, but I mean, I like the idea. Yeah.
You want them to be ready, and you need to mentally prepare them that, you know, like if things don't go well, they may be called upon.
Okay, I agree with you. So it looks like we have very little time, so I will need to rush. Right?
Correct, unfortunately.
Right. How do I advance the slides? Oh, yeah, here we go. Yeah. So this was, so what I like to do for these patients when I have morbidly obese patients, I do a delayed sequence nasal intubation, what I call delayed sequence. So put the patient to sleep, put the supraglottic airway in. Okay, you can do nasal endoscopy beforehand to make sure that there's going to be unobstructed pathway. But in obese patients, we know, I mean, it's usually not an issue at all. The posterior pharyngeal pathway is pretty much open. And that was the plan. So delayed sequence intubation, put supraglottic airway in, put the patient on a vent, 100%, bring the FeO2 to 90% or higher, while at the same time prepping the patient's nose in preparation for a sleep nasal flexible scope intubation. I didn't want to go with the video laryngoscope into the significant lingual tonsil, because as you know, lingual tonsil is just, you touch it and it bleeds, you know, and then, you know, my flexible scope is going to be gone. It was a backup plan, and another backup strategy was the combined approach, okay? So we talked about what we would do, and it's a question what type of video laryngoscope you would use here. So here, I would actually wanted to stay away completely from the vallecula where this lingual tonsil is. So my choice, and at Stanford we have the luxury probably of having multiple video laryngoscopes, which I think, by the way, all institutions should provide the anesthesiologists with different laryngoscopes, because they have different characteristics and they suit best for different patient populations. So the Pentax airway scope was my first choice because the blade naturally dips under the epiglottis, okay, in a Miller-type fashion. Stay away from the vallecula. So I had it out. I was working by myself, actually, without the resident, and everything. And the surgeons were in the room. They were just sitting by the computer, saying, Vladimir, okay, let's go. Okay, we have the case to do. So I asked them actually to take the pictures. I felt very confident. I said, it's going to be a great teaching case. You know, I'm going to show it at my airway course. So put this LMA Supreme in, put the patient on the ventilator, prep the nose, advanced the nasal tube in, getting ready to go with my scope, and I go with the flexible scope only, and I see this. All right, no problem. I have everything prepared, everything laid out. Take it out, put the patient back put the supraglottic airway back in, bring the saturation back up. Now going with the Pentax airway scope. I'm struggling to get it in, okay? I finally get it in, and this is what I see with the Pentax scope.
The video should work, Vladimir.
So, thank you. So something like could be here, but this is all lingual tissue, okay? And that looks like there could be the hypopharynx there, but I cannot visualize anything. I cannot lift it. Yeah, looks like the larynx should be up there. No. And it's probably the hemodynamic something. So I feel worse now. Okay, but go back in. GlideScope was not available at that time. Here we go, another limitation with the equipment and stuff. But put it back in, now I go for the AirTrack, another channel device that was available for me. So now the AirTrack, as you know, goes in the vallecula. I didn't want to go in the vallecula, but I have no choice. So AirTrack is in, and that's what I see with the AirTrack. Huge tongue, which I have difficulty displacing, so this is the uvula, and again, it's all the lingual tonsil and nothing else. You would think, but it was not. So what would you do at this point? Huh? Retrograde intubation. There's no, it's very poorly identified cricothyroid membrane. Okay, so yeah.
I would use a flexible scope because you'll be able to identify that in the trachea once it's moving forward.
The flexible scope cannot see anything. It's blood. That's it. I mean, you cannot see. You just get the red out once you put the scope in. So remember, oxygenation comes first, right? And then nasal. Now I talk to the surgeon. I say, is it really necessary for us to have a nasal tube? I mean, can we do something maybe more traditional in this particular situation? Say, oh yeah, Vladimir, that's okay. We can work with an oral tube. That's fine. So at that time, I had the LMA Fast Track available, and I put the Fast Track in. As you know, it's a great ventilatory device and also great intubating device. And reestablish the ventilation and try to intubate blindly through the Fast Track because the scope wouldn't work again because of blood and secretions, and couldn't get it in. I'm pretty good with the Fast Track. I mean, I have maybe like 2 or 3 patients who failed only, during my whole career. So I'm pretty confident with that. I cannot get it in. What would you do next?
I would.
Wake the patient up? Yeah, always a choice. But what's going to happen after? I mean, she's going to come back and we have the
I have
same.
a question.
Yeah.
Why did you keep the patient supine? Did you try to sit the patient up a little bit more to take advantage of gravity, detach the base of the tongue and extra tissue at the base of the tongue?
Not for the Pentax and for the air track. I mean, it's recommended that the head should be either neutral or
with respect to sniffing position, but not neutral in the sense of not head elevated. Neutral in the sense of not flexion of the lower cervical spine, extension of the upper cervical spine, and jaw protrusion like the sniffing position. But as far as
I did not elevate the back up, that I remember. I think for the Fast Track, you definitely want to have the head in a completely neutral position, as you know. But I don't remember specifically whether I probably tried different manipulations of the head and neck with the video laryngoscopy. But don't forget, so if you have the luxury of having an experienced ENT surgeon in the room, they can actually save the airway for you. And that's I call it the GEB, the gamma elastic bougie technique, which stands for get ENT bail you out, okay? And so they suspended the patient and then they intubated the patient. The tubular suspension laryngoscopes, as you know, they're highly effective in managing the tissue obstruction. They just push everything out of the way. And that's what they did. They suspended the patient and put the bougie in, and then we just intubated. And that's how the lingual tonsil looked for that particular patient. So pretty dramatic case, and just an example of how all the device, whatever the device you use, it may fail. And I think the teaching point here is be prepared with different backups when you deal with a difficult airway, and always think about the oxygenation ventilation pathway in addition to intubation. Patients do not die from the lack of intubation. They die from the lack of oxygenation. You have to remember that.
Just a curiosity, the bougie is upside down?
Yeah, the straight tip, easier to put through the suspension laryngoscope. Yeah.
Yeah, because it's straight. Doesn't matter.
You got it.
I think
you.
I would like to ask also, so Dr. Mackenzie said that departments should provide every type of video laryngoscope.
Ideally, yes, I believe so. Yes, especially as we move towards the era of universal video laryngoscopy. I mean, how many of you would want to continue to use direct laryngoscopy? No?
And
Yes.
Laura, do you agree on this with Dr. Mackenzie? And then I think we need to leave.
You would want to continue using video laryngoscopy?
No, I would like to continue to have
Direct laryngoscopy. direct
well,
laryngoscopy.
everything available
Everything
for now.
available.
All the devices of different
Well,
categories, definitely, because difficult airways are not all created equal, as we just said. There are difficulties of all kinds in all different kind of clinical situations. So we still don't know which blade is better in.
We all have these, right? Would anyone want to have a phone without a video camera?
I think,
That's my point.
thank you very much to the speakers, I think, and thank you to the audience for your participation. You all have a good evening.